Hello, everyone. This is Ben Knoll, Director of Patient-Centered Research at the Global Healthy Living Foundation, Creaky Joints patient community. And I'm also a co-PI for the Autoimmune and Systemic Inflammatory Syndromes Collaborative Research Group of PCORNet, and also a co-PI of Arthritis Power, which is one of the patient-powered research networks that was originally part of PCORNet. We've been conducting these monthly webinars to share information about research topics that patients have told us are of interest to them. This is a very interesting topic. We're thrilled to have an expert on the call with us tonight, Dr. James Lewis from Perelman School of Medicine at the University of Pennsylvania, to address the topic, how does diet affect your inflammation? So I'm pleased to introduce Dr. Jim Lewis. He's a professor of medicine and epidemiology at the University of Pennsylvania. He's also the director of Penn's gastroenterology and hepatology clinical research program and the associate director of the inflammatory bowel disease, or IBD, program. He's an elected member of the American Society for Clinical Investigation and the Association of American Physicians. And his research, in addition to being a gastroenterologist, his research focuses on optimizing the risks and benefits of therapy for inflammatory bowel disease, including through the use of dietary modifications. He's received funding for his research from the National Institute of Health, NIH, the Center for Disease Control, CDC, the Patient-Centered Outcomes Research Institute, which also funds Arthritis Power and our collaborative research group at PCORNet. And also funding from the Crohn's and Colitis Foundation and many other sponsors. So we're thrilled to have Dr. Lewis on with us today to talk about this topic and to share some of what he's learning from his research and some of the current projects, at least one of the current projects he's working on that we're at least tangentially involved with. So a couple of guidelines as we get started here with the webinar. Everyone is muted except the presenters, and so we would highly encourage that you ask questions, however. So even though you can't speak up or people wouldn't be able to hear your voice, if you see on the control panel, there's a space to ask questions. So you can certainly type questions there. I can already see a question that came in, I think, from someone asking if we can reduce the volume. I don't think I have a way of doing that on my end, but we can look into that. But we encourage you to ask questions as Dr. Lewis is presenting, and then I'll facilitate questions at the end to make sure we get through them. It's possible we won't get through every single question if we run out of time, but we'll try to address those offline, and then when we post this recording of the webinar later, we can include some additional information where we address those questions. So if you do have questions that you want to ask, try to get them in there, typed in there early, so we can get to them first. So we'll hear from Dr. Lewis about the first 30 or 40 minutes, and then we'll have time at the end, 15 minutes or so, for some Q&A with Dr. Lewis. With that, I will turn it over to you, Jim, and we'll take it away. So I'm going to make you the presenter.
Okay. Thanks, Ben.
Thank you.
Let me get that back. So hopefully everybody can see my screen now. There we go. Well, it's nice to be here, and hopefully you will find this interesting. As Ben told you, I'm not a rheumatologist, and so I don't personally treat a lot of people with arthritis or rheumatologic disorders, other than to the extent that patients with inflammatory bowel disease also tend to have rheumatologic disorders, such as arthropathy, arthritis, and ankylosing spondylitis. That being said, I think the concepts that I hope to speak to you about this evening in terms of how diet and nutrition might play a part in inflammatory and autoimmune diseases will translate over, even though I'm going to use inflammatory bowel disease as a background. When I talk about inflammatory bowel diseases, I'm speaking about Crohn's disease and ulcerative colitis. And so these are two chronic inflammatory diseases of the intestines. I bring this up at the same time as a potential conflicts of interest slide to note that many of the medications that are used to treat rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, etc., are the same medications that are used to treat patients with inflammatory bowel disease. And towards my potential conflicts of interest, I've served as consultant to many of these companies. Perhaps the only real potential conflict of interest that's truly relevant to this talk is that I've also been a consultant for Nestle Health Science, and I've had some research support from them as well. Okay. So you might ask, why should we care about diet? At least those of you who dialed in tonight obviously did care. In the world of inflammatory bowel disease, and I believe this is true as well for most of the arthritides, we know that genetics explains less than half of the cause of these diseases, which leaves us with the question, what is the cause of these diseases? It has to be some environmental factor. And the reason we know that genetics explain less than half is if you look at identical twins who share the exact same genome, if you will, there's less than a 50% correlation in terms of if one of the twins gets the disease, will the other twin get the disease? So that's one reason that we should care about diet. Another reason is that even our best therapies are not effective in all patients. And so it'd be great to have new therapies that work, even if those are diet. A third reason is that patients want to know what they should be eating. And I can tell you in the world of inflammatory bowel disease, and I think that this is probably true for most immune-mediated diseases, that the information available to patients over the internet is inconsistent and in general not based on evidence from research. Equally as important, and I'll come back to this in 10 or 15 minutes, is that patients tend to change their diets on their own based on what they've found on the internet, what a friend has told them, etc. And then lastly, because a lot of what I do in my day-to-day existence is think about research studies to try and answer these questions, one of the things that really got me interested in this is the fact that there's research that tells us that something in the lumen of our intestines drives inflammation. And I want to give you the basis for why I say this. I mentioned before that Crohn's disease is a chronic inflammatory disease of the intestines. The most common place that it occurs is at the end of the small intestines where they meet up with the large intestines, the colon. And one of the therapies for Crohn's disease is to surgically remove that part of the intestines. When you do that, the disease at some point will invariably recur. It's interesting, when people have very severe inflammation at the time of surgery, the surgeons will often create what's referred to as an ostomy. And they will create this in the small bowel above the point where they've sewn the small bowel and the colon back together. And that's this picture here. If you can imagine a loop of bowel being brought up to the skin so that the fluid and feces in the small intestine can empty out of that into an ostomy bag, as opposed to continuing downstream where it would get back to the area that the bowel was sewn back together. And what's fascinating is that the disease will usually not recur after surgery until this ostomy is reversed so that the fecal stream can travel down the small bowel and be exposed to the colon, suggesting there's something in the lumen of the bowel that drives that inflammation. Now, I can't tell you with any certainty whether it's the microorganisms that live there, is it the digestive enzymes that we're eating that our body produces in some way, is it the food that we're eating, or some combination? And this is a big focus of our team's research, is trying to understand that. But something in the lumen of the intestines is driving that inflammation.
Hey, Dr. Lewis, sorry, just to bust in for a second. Can you define a few of those terms, especially on that last slide, and also what you meant by the lumen of the gut? That may not be terms that are familiar to everyone.
Sure. So the lumen would think of the intestines as a hose. So your body is a tube within a tube. You have a tube that goes from your mouth all the way to the end of your intestines to your anus, where your stool comes out. And the lumen is just the inside of that hose. So something in that tract that goes from your mouth down through your intestines is driving that inflammation, where the surgeon sews the two pieces of your intestines back together. Okay, so if there's something in the environment that's causing this inflammation, one way to think about looking for the answer here of what it is to look at studies of environmental exposures before people were diagnosed with the disease. And there are lots of these different environmental exposures shown in the different pictures. If we had more time, I could speak to you about all of these, but I'm going to select just a couple to highlight this point. So one of these is breastfeeding. We all have to start with some diet. It's either going to be breastfeeding or formula feeding. And interestingly, breastfeeding is associated with a lower risk of childhood onset inflammatory bowel disease in most studies, meaning that the infant who is breastfed is less likely to be diagnosed with Crohn's disease or ulcerative colitis during their childhood years. It's hard to do those studies extending out into adulthood because, amazingly, many adults don't know whether they were breastfed or formula fed. Once we finish consuming either breast milk or formula, ultimately we move on to eating regular food. There's a few technical terms on here, but I can summarize this to basically say consumption of more fats, and particularly meat, tend to be associated with a higher risk of being diagnosed with Crohn's disease and ulcerative colitis, these two forms of inflammatory bowel disease, while consumption of fiber and fruit have been associated with a lower risk of Crohn's disease, and consumption of more vegetables with a lower risk of ulcerative colitis. And here's a study that I always find interesting. It was done in a large group of nurses who agreed to fill out surveys every couple years. And in one of the early surveys, they asked them to describe their diet when they were in high school. And then they looked at how likely they were to go on to be diagnosed with Crohn's disease. And the numbers that you see here are a ratio comparing those For example, the top line, those who consumed the most fiber versus those who consumed the least fiber. And when that ratio is less than 1, it means you are less likely to go on to be diagnosed with Crohn's disease. And when it's greater than 1, it means you're more likely to be diagnosed with Crohn's disease. So what you can see here, similar to what I showed you on the previous slide, people who consumed a lot of fiber in their diet, had consumed a lot of fish and a lot of vegetables, were less likely to go on to develop Crohn's disease. Whereas people who were eating more animal fat and more meat, where it says heme iron, that's really eating meat, were more likely to go on to develop Crohn's disease. So consistent with what I showed you before, but what's interesting to me here is this was their diet in high school long before they went on to be diagnosed with Crohn's disease. To put that into context, here's what we know about what Americans eat every day. Between 2013 and 2016, the National Center for Health Statistics estimated that more than a third of U.S. adults consumed fast food on any given day. You may be thinking to yourself, is that me? Is that not me? But that's a big number. And there's some logical reasons of why this is. One, it's super convenient. Two, for the most part, it tastes pretty good. And three, it's a pretty cheap way to get food. But it's probably not the healthiest way for people to be eating. So if you think about the implications of just these few studies that I've pointed out to you, it suggests that what and when you eat potentially influence your risk of developing these inflammatory and immune-mediated diseases, and that earlier diet may be more important than dietary changes later in life if your goal is to prevent the onset of the disease. But in honesty, most people don't come and ask about preventing the onset of disease. I see most people when they already have a disease and they want to know, what should I be doing? Well, there's a number of different ways that we can alter people's diets, and I'm not going to talk to you about all of them. In the ideal world, the simplest would be you just take a pill and it fixes your woes. And there have been studies of various nutritional supplements, like certain vitamins or fatty acids, given as a nutritional supplement. A second strategy is to take certain things out of your diet or add certain types of food to your diet. One thing to remember is when you take certain things out of your diet, you will invariably replace those with either more of what you're already eating or with new things, because we all need a certain amount of calories to continue to function. And then the third way is shown on the right, is instead of eating regular table food, we can sustain ourselves either with formulas that you could drink. So you could think of like OptiFast shakes or Carnation Instant Breakfast, etc. Or more often, really what we're talking about are things like Ensure or Boost, which you've probably heard of. Or in extreme circumstances, administering nutrition intravenously as opposed to having people consume the nutrition by their mouth. So I'm going to talk just about this last concept of using liquid nutritional formulas. A meal replacement liquid formula basically is a liquid that replaces all the nutrients that you would get from your regular diet. The protein or nitrogen source can come in various degrees of being if you will, pre-digested. There's can be variable amounts of fat within these formulas, and the sugars are typically glucose or fructose. And one thing I will point out is there's usually no or minimal fiber in these formulas. And they can be consumed in 3 different ways. Just as a supplement to get people extra calories. They can be used as what we refer to as partial enteral nutrition, sort of a technical word that says I'm getting about half my daily calories from the formula and eating the rest of it in regular food. Or what we refer to as exclusive enteral nutrition, meaning, in essence, I'm replacing all of my regular food with this formula-based diet. So I'm living solely off these liquid formulas. And the reason that this is so interesting is that if you take children with Crohn's disease, these formulas are quite efficacious. A couple other interesting things about them. One, it doesn't matter how much the proteins have been broken down. They can be intact or broken all the way down to just amino acids, the little small molecules that go into making a protein. But it turns out that amino acids taste terrible, and so we usually use formulas that have intact proteins because people are then able to drink them on their own. And the figure on the right just shows the line down the middle shows no difference. The big triangle at the bottom is a summary of all the slides together, pointing out that there was absolutely no difference in benefit based on the design of the formula. Equally as amazing, though, is how well these formulas work. So here I've summarized for you about 10 studies in children with Crohn's disease. And these nutritional formulas, about 60 to 70% of children had remission of their Crohn's disease within 4 to 8 weeks of living on just these nutritional formulas. This is substantially higher than what you would expect if you had given a child a placebo, like something that you didn't expect to have any therapeutic benefit. And in all honesty, if we had drugs that induced remission in 70% of people, that's a blockbuster drug. I'll also point out that children do better with this therapy than adults, and it's mostly because adults, we don't have as much willpower, or we don't have a parent forcing the willpower on us. And adults start cheating. They want the social aspects of eating. They really just don't do as well with this strategy. Nonetheless, this sort of study has always led me to believe of the importance of diet as a therapy. Here I'm summarizing for you a clinical trial, a small randomized clinical trial that compared one of these dietary formulas to steroids for children with Crohn's disease. And both groups got better. Over on the left, this is the proportion or the group means. So you can see these are symptom scores, and this is the diet group before they started and afterwards. Lower is better, so they got much better. This is the steroid group before and afterwards. They got much better. The CRP is a marker of inflammation. Both groups got better. But what you see on these last 3 areas would be similar to in rheumatoid arthritis, where you think about joint destruction. Here we think about bowel injury. So this is inflammation of the bowel is measured at a colonoscopy or on biopsy. And here the significant improvement was only seen with the nutritional therapy and not with the steroids. So just a bit of a comment about the use of these nutritional formulas in in juvenile idiopathic arthritis and rheumatoid arthritis, there's very little in the literature. This is a very ripe area for research, I think. In JIA, there's just a couple of reported cases and one uncontrolled study of 13 patients. But even in that one uncontrolled study of 13 patients, about 7 of the 13 demonstrated significant benefit, which would be fairly positive. In rheumatoid arthritis, in contrast, in 2 small clinical trials, there was no significant difference, although these were very small clinical trials, and it probably is a bit too early to completely write this off. All right. So what about going back to this idea of changing what you're actually eating in foods? I'll just point out that patients with Crohn's disease and ulcerative colitis change their diets all the time. So we did a survey of patients in IBD Partners, another one of the patient-powered networks, and asked them, what do you eat that makes you feel better? And what do you eat that makes you feel worse? Or what do you avoid because it makes you feel worse? And the only 3 things that really made people consistently feel better were yogurt, rice, and for some people, bananas. But there were all kinds of things that people ate that potentially made them feel worse. And it was not necessarily consistent between individuals. Nonetheless, there have been some clinical trials that have shown taking certain types of food out of people's diet led to longer periods of like inducing remission and sustaining remission as compared to continuing on your regular diet. Although I will point out that these exclusion diets were really different. So pulling these together is a bit dangerous, and the quality of this evidence is very weak. We're interested in some diets that have gotten a lot of press, and some of you may have heard of a diet called the specific carbohydrate diet. So this has been around for a long time. It was first reported as a treatment for celiac disease or sensitivity to gluten, one of the proteins found in wheat. That was because we didn't know what celiac disease was at the time, and this happens to be a diet that doesn't contain gluten. But people have used it for many, many different conditions, including Crohn's disease. It's quite restrictive. There's a long list of things that you can't consume, including most sugars, processed foods, starchy foods, milk products, except for yogurts that have been fermented for 24 hours. There's no bread, pasta, etc. Lots of things that look like they would be enjoyable. And what you can eat are unprocessed meats, poultry, fish, most fresh raw or cooked vegetables, most fruits and nuts, and then things like all-natural peanut butter, string beans, and I mentioned homemade yogurt that's been fermented for at least 24 hours. And the only sweetener that you can have essentially is honey. So it's quite restrictive, but some evidence of efficacy in uncontrolled studies. I'll tell you in a few minutes about a controlled study that we're doing. And then there's some other restriction diets or exclusion diets that are being tested as well. A friend of mine in Israel put together this exclusion diet where, again, about 70% of the people had felt better clinically, had normalization of a blood marker of inflammation, CRP, and had the lining of their intestines appear healed on colonoscopy. And again, you can see on the left that this diet excludes things like gluten, dairy products, gluten-free baked goods, animal fats, processed meats, products that contain emulsifiers, canned goods, and then my favorite is all packaged products with a due date. I'm not sure how Ari came to that last one, but this looks very promising as well. In the world of rheumatoid arthritis, there have been some small studies of a Mediterranean diet, Cretan diet, a vegan diet, and anti-inflammatory diets without really definitive results. We're particularly interested in a Mediterranean diet because it has added benefits of, in general, people who follow this tend to live longer. And in rheumatoid arthritis, at least we've seen some evidence, other investigators have seen some evidence that perhaps people have some improvement in their joint symptoms and decrease in pain. You know, but these diets are really complicated. If you think back to the slide that I showed you about the specific carbohydrate diet, trying to remember what I can eat and what I can't eat is a really hard challenge. And I always think it reminds me of this cartoon where Professor Herman stopped when he heard that unmistakable thud. Another brain had imploded. And so we really need to find more simple approaches to diet, hopefully, to allow people to follow these therapeutic diets. And so with that in mind, we recently conducted a clinical trial that we titled Food and Crohn's Disease Exacerbation Study, or FACES. And this was a study, randomized controlled trial of a high versus low red and processed meat diets for people who had Crohn's disease but no symptoms. And from that same IBD partners cohort, we recruited 214 patients and randomized them to one of the two diets. 118 followed the high meat diet, where they agreed to consume 2 or more servings per week of red or processed meat, and 96 agreed to follow the low meat diet, where they would consume 1 or fewer servings per month of red or processed meat. And a serving is basically like a 3-ounce serving of meat. So on the left, what I'm showing you is that the meat consumption was dramatically different between the two groups, as it was supposed to be, even though the low meat group wasn't perfectly adherent to our recommendations. Here's the high meat group. Almost all of them got their 2 servings per week in. Here's the proportion of weeks that the low meat group had 0 servings. Yeah, exactly. And then you can see a few scattered across there. But in general, the high meat group was much more adherent. But the difference in the amount of meat consumed was quite different. Unfortunately, what I'm showing you on the right is the rate of relapse of the 2 treatment arms. And so this goes at the top when nobody has relapsed, and then it's time along the bottom. And so over time, the proportion of people who haven't relapsed is declining. And these 2 curves are essentially superimposed upon each other, showing that this very modest dietary intervention was not effective, even though clinicians make this recommendation to their patients often. Currently, we're testing a much more rigorous intervention in a study that we refer to as DINE-CD. And so this study is again supported by the IBD Partners Patient Power Research Network, the Crohn's and Colitis Foundation, and PCORI. And so this is a study that's doing a head-to-head comparison of a Mediterranean diet to the specific carbohydrate diet, that very complicated diet that I showed you earlier, for patients who have mild to moderate symptoms of Crohn's disease, to see which diet will work better to reduce inflammation and to reduce symptoms of Crohn's disease. And one of the things that we've done to try and overcome this massive challenge of knowing what to eat is actually, for participants in the trial, we're delivering all their meals to them for the first 6 weeks of the study. So we've partnered with a vendor who ships their food to them. It arrives on Fridays. There's some degree of personalization allowed. All the meals are prepared and ready for just heat and eat. You can see them in the entranceway to my house, in our refrigerator, because I did 1 week on the diet. I wasn't going to have my patients and the other participants do it without having tried it. And then here's an example meal ready to eat. Actually, the food was quite delicious. We're about 2/3 of the way through recruiting for this trial. Within a year from now, we'll be finished and be able to let you know whether one of these diets was more effective than the other. So let me just try and wrap up by saying there's lots and lots of interest in diet in the world of inflammatory bowel disease, and I think in all immune-mediated diseases, certainly among patients. But we need to accelerate how we discover what the optimal diets are. The studies I've told you about, we're studying things that patients tell us work, but that may not be what the right diet is. And one way to think about that is through reverse engineering. So the one diet that we really know works is this exclusive enteral nutrition, the formula diets that I described to you. And if we could work backwards to understand how that works, it could open the pathway forward for diets composed of table food that might be equally effective. And indeed, within the world of gastroenterology, there's some papers that have come out just in the last month already beginning to suggest that this may be possible. So to wrap up in the last couple of slides, a little bit about thinking towards the future. We can start with what we know and what we don't know. What we know is that your medications won't work if you don't take them. And dietary interventions don't work if you don't eat the right food. But what and how much to eat remains to be defined. Similarly, how dietary strategies such as exclusive enteral nutrition work remains to be fully elucidated. And as I look to the future, I see a number of potential roles for nutrition in immune-mediated diseases, such as inflammatory bowel disease and rheumatoid arthritis. One is being complementary to traditional therapy, so being used in conjunction with our regular medications. And there's a little bit of data coming out of Asia that may be synergistic. Another is the idea of permitting a reduction, or in some rare cases, perhaps discontinuation of immunosuppressant medications. So those medications that suppress your immune system and make you at increased risk for things like infection and cancer. I'd love to think that we will have evidence-based dietary recommendations that are going to come from randomized controlled trials, so that patients don't have to be looking at inconsistent and poorly backed information on the internet. And at the same time that we do these clinical trials, it will be really important to study the host's genetics, their immune markers, the microorganisms that live within them, the small molecules that are in us, to try and understand the mechanisms. And if we can get to that, if you really want to reach to the future, I think it's possible that we could get to what you might talk about as personalized diets or precision nutrition, where we can tell patient number 1, you should be eating this diet, and patient number 2, you should be eating that diet, etc. Or perhaps we get all the way to the development of medications that work through the same mechanisms as the diet, making it much, much easier to achieve the same goal and allowing you to eat whatever you want. Even if we can't get to that last dream one of the pill that lets you eat whatever you want, if we can show that diet is a valuable therapy for illnesses such as rheumatoid arthritis or psoriatic arthritis or juvenile idiopathic arthritis or Crohn's disease, there are numerous commercial entities out there that I promise you will start marketing meals to make following these diets much easier. And let me say, I'm not endorsing any of the companies on this slide. I'm just saying I feel confident that there are entities that will make this easier for people to follow. So let me wrap up there. And Ben, I guess we have a little bit of time. We could take some questions.
Yeah, great. Thank you so much, Dr. Lewis. Very, very interesting stuff. And it sounds like there's still a lot that we don't know, in fact. So I'm just going to take the screen control back here just to show my slide. So, yeah, a few questions. The first question that comes through from one of the attendees, one of the listeners today, and just to confirm what you said in one of the early slides about some of the studies that showed that high fiber, high fruit or vegetable diets seemed to be better than the sort of meat heavy or meat based diets. Someone asked that one of the things they're seeing on the internet is that actually what they found was that meat based diets or paleo diets are the only or best way to lower inflammation. But it sounds like based on your presentation from, actual good research, good evidence from science, that would not necessarily be true. Can you comment on that?
It's a really good question, and I'm so glad that whoever's out there asked it, because I left out maybe what's a secret in this talk, which is, what do all these diets have in common? Paleo, specific carbohydrate diet, various anti-inflammatory diets. To really follow these diets, meaning 100%, I'm going to follow this diet, you have to do one thing, and that is you have to buy your own foods, buy fresh ingredients, and prepare your own foods. And the reason that may be so important is all of the various additives that wind up in our foods. I didn't have time to incorporate it in the main body of the talk this evening, but there's enormous interest in the effect of additives to our foods. For example, things like emulsifiers and thickeners. These are ingredients that are added to foods to give them better texture, better shelf life, better taste. And for example, if you were to buy fresh peanut butter, it'll separate out there'll be that sort of layer of oil on the top. But if you put emulsifiers in there, it stays nice and creamy. Same with ice cream. Like ice cream all has these emulsifiers in there. And in animal models, these emulsifiers have impacts on, for example, they change the microorganisms that live in our gut. They thin there's a mucus layer that protects our the lining of our intestines from those microorganisms. And actually in animals, they're more likely to gain weight, to have early signs of diabetes, and to develop inflammation in their intestines. Now, whether this happens in humans and whether this is the actual cause of people getting inflammatory bowel disease and other immune-mediated diseases is yet to be proven. We're just finishing a study right now where we've taken some healthy volunteers and given half of them an emulsifier-free diet and half of them an emulsifier-containing diet, and collected lots of different information samples from them. And so about 6 months from now, we'll have some more information on this. But a long answer to circle back that it may not be the meat, it may not be the vegetables, it may be all the other stuff. And if you go back to what I showed you at the beginning, those people who are eating more fish and vegetables and fruits probably were eating a globally healthier diet, perhaps more eating less junk food, more likely to be buying fresh ingredients and cooking for themselves. And certainly, you don't typically add stuff to, a fresh apple.
Right. So that points out one of the challenges of research in this area, or any research really, is trying to isolate the sort of cause and effect, because there are so many confounding variables or other factors that could be determining, the outcomes that we see. And so it's hard to pinpoint exactly what was the cause for the reduction in inflammation or a rise in inflammation, it sounds like. Indeed.
It's always a challenge. And the people who are skeptics will say, how can you figure out which was which? Even when if you do a clinical trial of a drug, like a drug versus a placebo or one drug versus another, you know exactly what was different between the two groups. When we're studying Mediterranean diet versus specific carbohydrate diet, both groups are getting food sourced from all organic sources, no additives, so that they have in common. But there's lots of different ingredients. Was it the bread on the Mediterranean diet? Was it the yogurt on the specific carbohydrate diet? Even if we see a difference between the two, we won't be able to pinpoint down to which specific piece drove that difference.
Right. So a couple other questions have come in, and then I've got a few too that we're interested in. We know from our own patient community here, but one question came in about the types of vegetables. So often people in our community talk about nightshade vegetables or sunshade vegetables, like tomatoes or eggplants and so on, peppers. There's among a lot of patients, there's a sense that those are pro-inflammatory, that they seem to bring on inflammation in people with RA, for example. And this is a question from one of the listeners today. What can you comment on that? Is there any research you're aware of that talks about that sort of category of vegetable, that sort of nightshade vegetable?
Yeah, so there's not a lot. There's a physician out at Scripps Clinic in La Jolla who has done a study of a diet that's referred to as an autoimmune protocol diet. It's not just a diet. You make lifestyle changes with it as well. This was an uncontrolled study, but a part of that is gradually taking nightshade vegetables out. Again, there's so many changes made in the course of that study that it's hard to know whether any of the effects that were observed were a product of the nightshade vegetables. That's the sort of study that could probably be done fairly easily. One group gets nightshade vegetables, one group gets sunshade vegetables. Let's see what happens if you could do it over a long enough period of time.
Great. Okay, good to know. But it sounds like there's not any definitive research or evidence either way at this point. Okay. Another question that's great when you're a researcher, you love to hear this kind of a question. Someone asked, how do we become part of a study? So, for example, the Dyne CD trial that you mentioned earlier. What is there? Can people still become part of that, or is there a way to learn about other studies? I know for in general, there's the clinicaltrials.gov website. If people aren't familiar with that, we can post it here, where people can look for for trials across the country that they might be eligible for. But I guess what would you say to someone who wanted to know how they could get involved in a study in this area?
Yeah, so it's a great question. First of all, if you happen to have Crohn's disease with mild to moderate symptoms, we would love to have you. We have investigators all over the country, and we can ship food anywhere in the country. So hopefully you're relatively close to where we have investigators. Ben, I totally endorse your approach. I mean, you can search around for individual studies websites. We have a website for the Dyne CD study, but clinicaltrials.gov is the best place to start. It'll get you the ability to search for under your disease that you're looking for, and then you can go through the various types of trials that are available. Are you interested in additional characteristics? Are they looking for people who have active symptoms, people who are in remission? Are you looking for a drug trial? Are you looking for a dietary intervention trial? Some other behavioral intervention? It's a quite useful tool that to much credit goes to the developers of it to help patients find clinical trials. And we get actually lots of people who reach out to us about Dyne from clinicaltrials.gov.
Oh, great. Okay, that's good to know. So clinicaltrials.gov is a good website that we've been recommending too. So we'll keep doing so. So a question that came up from one of the listeners and that we had ourselves was, if you could tell us a little bit about the connection between gluten and inflammation. So what does current research tell us about that connection? Is there a link? Is it limited to people with a celiac disease diagnosis? I guess, what do we know about that?
That's a good question as well. We know the following. So certainly people with celiac disease have inflammation of their intestines, particularly the beginning of the small intestines, when they consume gluten. And there's another group of people who have intolerance to gluten in the absence of inflammation, because gluten is somewhat difficult to digest and it leads to a sense of discomfort. More systemic inflammation is not well documented, although, for example, you saw that Dr. Levine excludes gluten from his diet. There's no gluten in the specific carbohydrate diet in both cases because the inventors were under the impression that gluten is a potentially inflammatory agent. I don't know as much about the effects in rheumatoid arthritis or the arthritis. In Crohn's disease, probably more than 50% of people have at some point tried a gluten-free diet. And depending on how well they did it, it's hard to say. And of those who try it, maybe a third or so remain on it for longer periods of time. I just would caution people that following a gluten-free diet does not always mean you're getting the highest quality food. When you take gluten out to make things taste palatable, you have to replace it with other things, and so often it's replaced with lots of sort of sugars and oils and things of this. So going on a gluten-free diet, if you don't need it, is not necessarily the best idea.
Okay, thanks. Couple other things that are popular topics that come up a lot from our patient community are pre and probiotics, and I guess understanding what are they and what is the difference between them.
Mm-hmm.
And before even that question, I think a lot of people ask us about something they call leaky gut or leaky gut syndrome, which I understand is actually not a medical diagnosis at all. But people hear about that all the time. And so I guess we wanted to get your thoughts about what people refer to as leaky gut syndrome. Is it a real thing? Is there a connection between autoimmune disease and inflammation and leaky gut?
Leaky gut is this concept that not to get too technical, but that for example, the tight junctions, these tight cement-like seals between the cells that line your intestines aren't as tight as they should be, and it's allowing various parts of the substances within the lumen, again, the insides of your intestines, to leak into your bloodstream. And these could be small molecules, fragments of bacteria, etc. Various toxins. People sometimes link the concept of leaky gut with this idea of brain fog and not being able to think as clearly as people would like to. It's really hard to study. There are some tests that look for what's referred to as increased permeability, like how easily things go through the intestine wall. But not clear that that's really the same as this concept that people think of as leaky gut. There are diseases where the lumen of the gut is less sealed less well, and we know that stuff gets through. So, for example, people with cirrhosis of the liver, this happens to, and they can have problems with their thinking for a variety of reasons, but that may be one of them. So does it lead to inflammation? I'm not sure. I wouldn't 100% exclude it, but I'm not sure that it's always the source. The second question had to do with pre and probiotics. So probiotics are the idea of putting in a healthy or favorable bacteria in your intestines to consume these, typically in the form of a pill, and hoping that they will provide beneficial effects for whatever disease you have. Prebiotics are putting in the food for bacteria, hoping that it will lead to healthy bacteria growing. In some ways, you can think of as undigestible fiber as a prebiotic, but there are also other prebiotics that you can purchase, things like inulin, etc. Most commercial probiotics that you buy at the store, actually, I think of as tourists. You take the pill, they go in, they look around, and then they leave out the other end. They never became citizens of the community in there. The challenge is how to make these beneficial organisms citizens of the community. There are people who are doing studies of things like transplanting fecal microbiotic transplants. This is like taking the stool from one person and putting them into someone else, so putting whole communities in. And for diseases such as Clostridium difficile colitis, very effective. Probably effective for ulcerative colitis, one of the inflammatory bowel diseases, and certainly being explored for other things, some potential for benefit in diseases like diabetes. So that's the ultimate probiotic, if you will. You put an entire community in, but it'd be nice to find much more contained ways to give controlled certain organisms and get the same beneficial effect.
Great, thank you. I I know we've reached the limit on our hour here. I don't know if you have a couple more minutes just to address just two more questions, and I'll give them both to you now, if you don't mind.
Okay.
The one is about exercise, the impact or the sort of role of exercise in this relationship between diet and inflammation. And then the other question has to do with the diagnosis of ulcerative colitis or Crohn's disease. Once someone has that disease, will they always have it, or can it get better? Can it, I guess, either go into remission permanently or go away entirely?
Perfect. Exercise is easy. Yes, you should exercise. The original studies didn't really point out any association between exercise and the course or the risk of inflammatory bowel disease, although some newer studies suggest that exercise may be protective. And the corollary of that is you should sleep a lot. People who have less or disrupted sleep were more likely to have relapses of their disease, and I suspect the same will hold true for essentially any of the arthritides. I know for sure for osteoarthritis, exercise and weight loss is like, the mainstay of therapy. So double thumbs up to exercise. The second question asked, once you have one of these diseases, do you have it forever? And in 2019, the answer is yes. Will that be the case forever? I hope the answer is no. Right now, the best we have are therapies that result in prolonged periods of remission where people have no sense that they have the disease, and that's pretty awesome. And if you could do that for the rest of your life, maybe you could argue that the disease was gone, except for the fact that right now we don't have any therapies that we can give for a short period of time and make the disease not come back. And I think that's true of Crohn's disease, ulcerative colitis, rheumatoid arthritis, psoriatic arthritis, all of these immune-mediated diseases today. Will that be forever? I certainly hope not.
Great. Well, thank you so much for addressing this very interesting, useful topic, Dr. Lewis. I'm excited to learn more about this topic based on what you shared with us today. And just as a reminder to everyone listening, we record these webinars, and we'll do a little bit of editing just to clean things up a bit, and we'll post them with a summary on the Creaky Joints website, and then send a note out to everyone who attended with a link so you can find that and revisit this topic in the future. So again, thanks so much, Dr. Lewis, for tackling such an important issue for a lot of patients. And we wish you well and good luck with your research. And if anyone is interested in your particular study, as you mentioned, they can either reach out to me or us here at Creaky Joints directly, and we can put them in touch with you. That's probably the easiest way. Or we'll, they can find it through clinicaltrials.gov.
Great. Well, absolutely my pleasure, and good luck to everybody.
Thank you. Bye-bye.